Okay, so we should be back live on Facebook, and um, and for anybody, let's see, out there who's on Facebook who is trying to join the Zoom directly, welcome you on that as well, and that's fine. And but so it is bit.ly / CalCare, CalCare -office -hours, all lowercase. Looks like Paul Newman is here. Let's see, make you Paul. All right. Yeah, I goofed on this one and got to give a monologue. But welcome, Paul. And
thank you, Ron.
Thanks for your persistence in trying to get on here. Let's see what's going on in the chat. Oh yeah, Dennis was here, but he's going over to going onto Facebook. So, well, let me, as people are joining, let me share a screen, because I had started to talk about, what a single payer program is, that kind of thing. And then some of the features of CalCare, which is the bill to do single payer in California, or the Guaranteed Healthcare for All Act, would create this program, CalCare. And it's a program that would do, first of all, universal coverage, so that it would cover everybody in the state. And that's actually a major step forward from what we have right now, because we have millions of uninsured people in the state of California. Lots of folks who lost insurance, who had it during the pandemic, lost it because they lost jobs, and then all kinds of other folks who people can't afford it. We really lock out our immigrant populations in a bunch of ways. Partly the fill out of the federal programs won't take care of the undocumented. So CalCare would give us universal coverage. It would be a single public program. We talked about that. Benefits pretty much would be more comprehensive than anything that's out there now. I think that's pretty safe to say. Or it would be maybe maybe some of the super most gold-plated, platinum-plated, titanium-plated stuff that's out there would be comparable. And another thing that changes when you have a single payer is that you stop having these super narrow networks. So one of the problems is you have all these different insurers, and they only have a deal with certain doctors or hospitals. That's what's called narrow networks. And those create all kinds of problems. Sometimes there's nobody nearby somebody, or somebody has insurance, but there's nobody who will take their insurance who's nearby, or they require lots of travel to get there in a way that makes it impractical. All kinds of problems. And so another big thing is that it would be free at the point of service, where you don't, and that's important, that when you go to get healthcare, you don't stop and think, oh, can I afford this? You say, do I actually need healthcare? And then you go get it. And so you don't have to be like your own self blocker. And so, which we don't really want that. I think people think that there's sort of a misguided view out there that that's a very important way of saving money. It's not the big driver of costs in our healthcare system is overutilization through people accessing too much healthcare, or at times the kinds of things that are like that are use of emergency rooms, but those are often used because people are in an emergency, because they didn't have care beforehand that was available before they had an emergency. So that's the crisis point, is the emergency room. And then the just transition. So knowing we're changing systems from one healthcare system, a kind of crazy healthcare system that employs a lot of people doing some things that we don't necessarily need to do. Like, we don't need an army of billers if there's one program that has kind of a simple billing system. So the current army of billers that we have, they would be looking for new and different kinds of work. And the program, and by the way, this bill was created by the California Nurses Association, CNA, and they care about working people. They're a union that represents working people. They know about issues related to like people losing jobs and stuff in healthcare. And so it's not that they want that. So what they want to do then is what's called a just transition. And we all want a just transition that, like, just as, for example, when we move our economy off of fossil fuels, we need to find good, meaningful work for people who do work in the fossil fuel industry. We also want to do that in healthcare, and that's the idea of the just transition, and the bill has provisions for that. And then finally, like the main incentives in providing care are the need for care, that people aren't, hospitals or doctors or other providers, they're not paid to deny people things or basically the incentives are give people care when they need care, and that's the main sort of program. So that's a nutshell of what CalCare is. And let's go to questions. If people have questions out there, I realize we might have, I don't know if we have a small audience on Facebook or not, and I don't know if either Steve or Paul or Dennis, who are here in the Zoom, if you guys have any questions, or if you see, let's see. Oh yeah. Okay. So Paul asked an interesting question, and you mentioned in the chat, which is that currently the COVID pandemic has profiteering all over the place. That's right. To take a trip on airlines, you have to pay up to $250 for a test. And so you might say, well, how would that be different under CalCare? Well, the answer is that if a test was medically necessary, then you would go to someplace and get it. And if the medical necessity is to be cleared for safe air travel, then that's medical necessity. So it would be paid for. And that's the answer to it. That there's no reason to believe that would be somehow outside. I mean, ultimately, the bill has a section that covers the benefits, and it's sort of an exhaustive list. If you think about what the benefits, what healthcare benefits are, they are actually a whole, like, tremendously large number of different things. So if you put every known possible thing you could get from healthcare or related to healthcare in a bill, that would be like, it would look like the phone book. So it's not quite that exhaustive, but it is pretty clear that lab tests and like screening lab tests, which are just part of life in different ways, for example, some people, there's lots of jobs where you need to get, for example, my jobs, I have to have a tuberculosis test every year to make sure that I'm not giving people tuberculosis when I take care of them. That's been a problem in the past, where people in healthcare could occasionally have some low-level cough that they thought was, cough variant asthma or something like that, and actually they've got tuberculosis, pulmonary tuberculosis. So we have a system where you're supposed to have a test once a year, and this blood test or a little PPD, like a prick test, and that is, it's sometimes paid for by employees, but generally stuff that plans cover if you need, generally if you need it for work. And I think that this would be an example of something that would be covered. Ultimately, big coverage decisions would be made in more detail by the CalCare board at the level of policy. Now, the CalCare, that board also there's kind of an advisory committee that's there to help think through what would be good policy for the state in terms of things that are covered or not. But overall, those decisions would be made based on, what do people really need, or what does the public need? What do individuals need? You always have situations that will fall just outside or just beyond or way beyond what somebody, what a health plan, including public health plans, would think to cover. And so there may be situations where there has to be kind of adjudication of individual decisions. We've talked about that at some of our other office hours sessions. This is actually our 19th office hours session. So we've covered a lot of ground over these 19 sessions, but that's okay. We always want to keep returning to things that come up, but that's what I think would be the case with that test. And yes, well, one issue in terms of profiteering is who makes money. So there is institutions in CalCare, big institutions would be paid for on what are called global budgets, not on fees for service. Individual doctors would be paid fees for service. So there's still a question of whether some commercial lab could be out there, and it's more of like a vendor, I guess, and maybe could charge that money, that kind of money. But it's also the case that institutions would have budgets as part of their budgets to do lab testing where that's relevant. So that's sort of an interesting sub-question in there. But you wouldn't be stuck with that, Paul, paying for that. That's for sure. That's for sure. What do you see? Anything else out there in questions that you've got eyes on? Yeah. Who are you, Paul? You're suddenly either so still that maybe you're frozen, or is that on my end? Waivers. Okay. I see in one of my sources a question on healthcare waivers and what that's all about. So, and I mentioned this a little bit in the intro for some of the people who are on Facebook. Oh, looks like we just lost Paul. I thought he might have dropped off. Maybe he'll rejoin us. So, but I saw a question out there that was on waivers. So what does all that mean? So there, in order for a state like California to do healthcare as a single payer, it needs to collect all of these federal programs, money spent by the federal government in things like Medicare, the Affordable Care Act, Medicaid, which is called Medi-Cal in California, into one pot of money. And the part where the federal government would redirect money it normally spends by sending it to insurance companies or sending it directly to providers like hospitals or doctors or other healthcare providers, to the place where that would happen that's different would be this kind of federal waivers. So states and the big federal healthcare laws, particularly the Affordable Care Act, has a whole kind of legislated waiver provision. So a state can say, okay, we want to do single payer in California, can apply for healthcare, apply for these waivers. And then there's a set of criteria that the federal government is supposed to follow. And if the people in the executive branch are cooperative, then they would say, okay, you get your waiver. And if they, for example, maybe they weren't cooperative, well, then a state could potentially sue the federal government to force them to follow the law. But there's just specific actions that particularly the Secretary of Health and Human Services, under at least some of the statutes, would say have to follow if states apply for waivers. There's been a whole lot of discussions over the last several months about like kind of the order of events for waivers. Like, can you apply for a waiver first before there's a bill, or do you have to have a bill passed to apply for waivers? And that's been, let me just say, I continue to hear different opinions and interpretations of the law. And so, but I think one thing that is clear is that at some point in the arc of this process, the governor of the state of California, who is currently Governor Gavin Newsom, would have to say, okay, we want to do single payer in California, have to apply for waivers, and the federal government would say that we would have to agree to them in order for the program to not just be like a good idea, but to actually happen, in order for all the money. And the reason you can't go it alone as a state is there's so much money being spent in taxes, there's so much tax money going out of the state that's sort of earmarked for healthcare that like you got to collect that. So you got to get the part of it in there. I think everybody agrees, at least on that point. So there's some thoughts about waivers. Any other thoughts or questions out there from here? Welcome, Erica. I see you have your hand up. Go ahead, fire away.
Yeah, so I've been looking at, this waiver stuff for a while, because there's so much, it just seems like misinformation. But actually yesterday, or maybe it was even today, on our Allies Signal thread, the application was dropped in there, as well as an example of Ohio applying for the waivers. And it clearly states that you have to have enacted legislation attached to the bill. So you have to have a bill. Otherwise, it's like they don't know what you're getting a waiver for. It's like if I go to the post office and I fill out my form, but I don't have that picture attached, they're going to hand me back my application and say it's incomplete. And so I don't know.
Do you have it? Can you share it, the application form on the?
Yeah, let me see if I can get it and drop it in the chat.
And I mean, misinformation. I mean, different understandings probably of the law. I mean, maybe people just really don't get it right. But what was Ohio applying? Because they weren't applying for a single payer thing, so they must have been applying for something else.
Sorry, I was I'm trying to find it.
Yeah. No,
but
that's
it's
okay. We can
it looks like they were applying for a 1332 waiver. And they didn't have it, it got returned because their application was incomplete. It's like, this is not, it's not a negotiation. It's like literally it's an application, like at the post office, and it's either complete or not. Like if I don't put my name, who that passport is for, and I have the picture and everything else, it's like, well, who is the passport for? We can't issue an application if we don't know what it's for or who it's for. Like, so this would be for AB 1400. Like it has to be it specific. It can't be like someday Medicare for all bill.
No, yeah, I do that. I certainly, it's hard to imagine, right, the people in the federal government being like, yeah, you can have the money and hope you figure out a good way to spend it or something like that, because right, they have like certain criteria. But it could be that the meaning, if like maybe the waiver application describes that in detail. And then you're like, okay, well, then what it describes, maybe it describes something like AB 1400. I certainly just can't comment myself on direct knowledge on that a bill has to be passed first. I've certainly heard a number of people who don't think that that's true. And I've heard some people who think that that's true. And so I mean, I understand somebody might be right and somebody might be wrong in that. It's not, but also there are yeah.
Sorry. It's going to take me a minute to find it and drop it in chat. So I'm going to do that. But we have a bill, AB 1400, and everybody needs to be working to push this bill, regardless of if they're confused or not on the waiver. And we need all hands on deck. We have 5 months for this bill, which is amazing. So give me a minute to find that stuff and I will drop it and then come back.
Sure. No, but I mean, if I'm definitely happy to show that, or to show something like that so we can look at it. And if but I do think that I don't know, it seems like there's, like, for example, there was one of the rallies happened yesterday. I mean, I could just name other people who at least have had eyes on this process and feel and have at least some different interpretations of what's out there. Ultimately, the magnitude of the state of California doing single payer is not, I think, quite something that the people at Health and Human Services would look at in a very dispassionate way. It's such a big deal that I think that no matter how it unfolds, it won't quite just be like a postcard or like a post office application for something or other. It's like sort of too big a deal. Now, of course, the federal government can reject stuff for good or bad reasons. So if, for example, I think one of the main things is that has been observed over time is that if in California, without the leadership of the governor on the legislative side and on the because they can have to sign bills into law, and on the executive side, and I would call the waivers like a thing in a kind of an executive type action, that without that piece of it, there's definitely there's no single payer in the state. So in terms of then all of the range of efforts that are out there for this bill to pass and to be enacted into law, we know that we need actions by the public because there has to be public support. And we need actions by the legislature because the bill is a law. And we need certain actions by the governor because it's a law, has to be signed into law, needs leadership in terms of the budget in the state and the way that the executive branch sets priorities for the legislature, needs to do waivers, and needs to do and needs to just sort of lead on the implementation. And so all of those represent, they're just all part of making it happen. And I do get that some people have focused on different aspects of what order these things have to happen in. And I would say every single piece is necessary, but not sufficient to have a single payer bill. So they all matter, and all those efforts matter. And if really, I think in some ways the waivers thing is sort of a surrogate for just saying the governor has to provide leadership on the issue. or as we've seen time and time and again, without gubernatorial leadership, it doesn't happen. It just doesn't.
Yeah,
it doesn't happen. So those are political considerations, but
I mean, I think everyone would agree that we need to have Newsom championing,
yes.
Particularly this bill. So it gets frustrating to just say, hey, you know, focus on the waiver, Newsom. It's like, no, Newsom, use your bully pulpit to get your Democratic supermajority legislature to get this bill on your desk and sign it. That is what we need him to concentrate on. We have 5 months to do this. You can move forward with the waiver at that point. So we really need to be pinpointing our ask to Newsom to get him to champion this bill, AB 1400. So I just want to say really quickly, the application was dropped in the chat and I've pulled up. There's where I pulled up just on my phone a screenshot of, it has these points, like you need A, B, C, D. It doesn't actually say A, B, C, D, but it says a detailed 10-year budget plan that is deficit neutral to the federal government, a detailed analysis of the impact of the waiver on health insurance coverage in states, a description and copy of the enacted state legislation providing the state authority to implement the proposed waiver, and a detailed plan as to how the state will implement the waiver, including a timeline. So that is where it says in the application. But really, I guess my point is enough about the waiver and focus the ask on get AB 1400 on his desk to have him sign it.
Yeah, well, I had seen there was a question about waivers out there. And
no, I didn't mean that.
That's why I brought it up. But
yeah. No, I wasn't saying that to you, Ron. I wasn't saying that to you.
but yeah, no, I mean, I'll actually here, I'll share.
I just meant enough of focusing Newsom on the waivers and get him to focus on passing this bill. That's what I meant. Not enough of you, Ron.
Yeah, no. I know. I got it. Yeah, and now I'm sharing it. I see what you are talking about, and I'll highlight it here in blue. Can you guys see that? Can you see what me sharing the? Or can you see this like text shared?
Yes.
Yeah. But maybe can you see something I highlighted in blue? No, not quite.
Yes.
Yeah, so that's a description and copy of the enacted state legislation providing the state authority to implement the proposed waiver. So let me just say that at least the plain reading of that would say, oh yeah, you have to have a bill passed first. And so let me just say that I see exactly what you're referring to there. And that maybe we could leave the general discussion at that, which is that we need the governor's leadership. And that if, for example, if that leadership is never applied on the passage of a bill like AB 1400, which is the bill that is in front of the legislature right now, there won't be single payer in California. So we do have to, I agree with that completely. Okay. So Chris Shimizu asks the structure. My question is about timing of actually rolling it out if it were to pass. So I'm reading a question that's in the chat, which says like okay, so let's say the bill passed and was signed into law, was part of the state's budget, and the waivers were obtained, or well, actually, maybe now you're at that point where you now have to apply for that. You don't have that ready to go because you've waited till the bill passed first. Maybe you have it all ready to go, but now you send it off, and now then there's some period of time that's up to the federal government to make their decision. That could go to court, or that could just be done straightforwardly by the federal government. Then at that point, and also there will have to have been taxes that were defined either in the current legislation or in future legislation. So then if all those things happen, the CalCare board exists, it has all the money, then how fast till everything can be replaced? And I actually think that our current bad system can be replaced. I don't think the world completely knows the answer to that question. So you do have some past examples, which were Medicare's, when it was passed in 1965, it was up and running in like a year. And so I sort of think that on the one hand, with technology being what it is, that we might be able to do some things faster than they could do then. But there's also a lot more complicated and stuff in place that has to be rearranged, including, for example, that if you look carefully at the bill, the individual providers and the institutions have to sign contracts with the state. And so a whole contracting apparatus has to be created, and maybe not all at once, but over some period of time, everybody has to sort of do contracting with the state. And so I kind of guess, my guess would be, if you pass a bill, with taxes, that you're probably a year to two from seeing something that looks like single payer in California. What do you think? Dr. Bill has his hand up. What do you think?
Thanks, Ron. And I agree with you. I have not seen anything that says definitively how quickly it can be rolled out. I would just add to what you said already, is that the systems already exist. They're already in place. So what's done by the Center for Medicare and Medicaid Services federally, and then what's done at the California Department of Health to incorporate that into Medi-Cal, that creates the Medi-Cal system, they're already in place. And so it just needs to be expanded to include everybody, instead of restricted to, say, people below a certain income or people over 65. So, so those kinds of things are not as big an impediment as you might think. And it's the boards that we talk about a lot that will assure quality of care and reasonable reimbursements to providers and hospitals. All of that is in place already. That already functions, except for a subset of the population. We just need to get everybody under that umbrella instead of just some people. So I think you're absolutely right. It can reasonably be done within a year or two. One huge stumbling block is this proprietary medical information sharing between various provider groups, hospitals, clinics. That's been kept exclusive because of insurance companies, and so that needs to be freed up so that so all provider groups and hospitals can share information that way. It's not, hospitals and clinics are used to protecting personal confidential medical information, so that's not the issue, and HIPAA violations, that kind of thing. The issue is, is if you walk into a clinic or a hospital, are they going to have the information they need to treat you if you've been, previously a patient with a certain group, that kind of thing. So that's an IT issue. But once the government says that that that's no longer proprietary, they have to open that up to allow that to happen. But again, I think that happens within a year or two, and actually it's quicker than say like in 1965, or by when somebody came under the care of Medicare and they went from one doctor to another. It might take months to be able to get that medical information from one doctor to another. Now, hopefully, we have the electronic systems in place that could happen, very, very quickly, if not even instantaneously.
Right. So the bill actually has very little in it about healthcare information systems in detail. And one of the things is that we do already function, as you said, without that. So for example, in fact, many people with some of like the fanciest insurance, like PPO type insurance, where they can kind of go anywhere, go to a bunch of places that actually can't talk to each other very straightforwardly. And actually the bill does not, I don't think that little piece of it, I would need to look back, because my recollection, I haven't read that part, was that there was very little, just a little bit about that. But I think that the bill does ask institutions to make some very big changes in how they function. And like, for example, I'll give you some examples of some things that the bill would do that I think would take a while to do. So the bill is going to turn institutions that were potentially for-profit into not-for-profit institutions, and there may be sort of like legal work and stuff like that is involved in institutions changing the way they operate, but also how, like, if you have a budget as opposed to just like a bunch of different money coming in, it may approximate something like what you were doing, but it may change things within institutions. Here's another thing, which is that the bill, we have a really unequal distribution of healthcare capital goods in California, right? Like we have places where there's a bunch of hospitals nearby with a bunch of fancy equipment. And then we have all kinds of like healthcare deserts and islands and things like that. And the bill really anticipates doing global budgeting aimed also at capital costs. And that's a way to address big inequalities in our system. But that doesn't put a hospital up within 2 months in your neighborhood if there hasn't been one. That gets the process going for a hospital to be built in your neighborhood if there hasn't been one. And so, I think that the way I imagine it is there's going to be phases of stuff, and that a fair amount can happen quickly, because it's not like we are building the hospital, like the whole system from scratch. And so I think that the ability of people to have health insurance and go somewhere and get care should be able to happen, I think, relatively quickly. But just everything, like if you saw like the changes that happened when the Affordable Care Act went up, there were hiccups and stuff in the beginning. There were a lot of things that didn't go totally smoothly at the beginning that now people don't talk about too much. And this system would also have some advantages over that, like everybody's in it, so there's not a question of like having to sign up, that kind of thing. So I think it's a really good question, and I've even seen some recent work done related to this other bill project that's out there that looks at some more broad issues in the healthcare system in California. This CalCHA bill project that I and some other people have been looked at. Some of the people working on that have actually started to build a timeline for implementation for that. And they've thought about a lot of things, right? Like for example, you actually have to have some time invested in educating the public. Like you have to let people know that their insurance company is about to change. I mean, it'll probably be pretty big news, but it's just one example of many things. Like it takes people a while to sort of understand that some big changes happen. So, so let's see. I have a question about what you were talking regarding profits and nonprofits, but I've talked a lot and don't want to hog the questions. No, well, I've talked a lot.
Fine, you don't have to read that out loud.
No, you haven't. Yeah, sorry. I just want to address it. There's no such thing as having too many questions.
I'm red now. No, I think
no.
there was something. I think there's other people with other questions before.
Yeah. Okay. No. But okay. Well, if Paul, so then we'll definitely come back to this question. But if Paul, did you see any questions on Facebook that might have appeared before a question hog through another question? I'm not.
Let's see. This is from Jackie Hidez with
I think that's short for
Hernandez, right?
Yeah.
Yeah. So, oh my God, my connection. Anyway, with Newsom championing the AB 1400 bill, the DNC party and the assembly members would most likely vote for it. So it's so important that Newsom campaigns on this bill now, correct?
Well, that's a political question.
Right, it's about time, in other words.
Campaigns on it in terms of, so I think maybe she would, it's so important that the governor get behind this that I think it's pretty right to say it's hard to imagine this passing without the governor being behind it. And from some of the other discussions, the governor has to be behind it. So then there's this political question she may be asking, which is, for the recall process, should he be making it a kind of a recall issue? And then in 2020, I guess assuming he survives the recall, for 2022, should it be a main campaign issue? So maybe that's sort of the nature of that question. And I see hands up. I don't know. Dr. Bill, do you have thoughts about that?
I do, and I'm not one to hold my tongue on things. So I'm going to chime in on the political question and just say, kind of like the state of politics right now in regards to, I think the governor has his eggs in one basket, and that is the Healthy California for All Commission. Now, we can look at it as being kind of farcical, like a dog and pony show, because it has been at least, or appeared to be at least, loaded up with a bunch of industry sycophants. But there has been a decided shift on that commission in adopting the actual charge of the commission, as was seemingly at least directed by the governor himself, which was to figure out how we put into place a single payer system. So I agree with the nurses, and especially with Carmen Consti, who's on the commission, that what they should be doing is modeling, the state to adopt AB 1400. There's no doubt in my mind that they should be doing that. And then if various partners in the coalition, have issues with AB 1400, they ought to be working cooperatively to figure out those issues and get them ironed out. So, but if we're all in agreement, I think we are, that Governor Newsom is kind of the linchpin here, then it seems to me that the point of leverage is the commission. And we are seeing a change in political persuasion on the commission. And where more and more of them, we have even kind of some new appointees and even old appointees who seem to be moving our way. We used to have 2-3 people solidly on our side. Now I think it's getting upwards of 5 and 6, and that to me is a significant gain in a 14-person panel. You know, that's starting to be more than just a dog and pony show. And you know, the governor may not show his hand here, or which he would. I mean, I think it would guarantee his beating the recall if he did, you know, but he won't for whatever reason. If that's his choosing, and maybe even at his own demise as regards to recall. But it seems to me that's the point we ought to all be talking about, is how does he push those members? How does the governor push those members of the commission to actually do what we all think needs to be done, which is to model their work on the bill, on AB 1400, and, you know, whip it into whatever it needs to be to get it passed and signed.
No, well, so thank you for that. Yeah, it does seem I've caught some fewer, most recent commission meetings I haven't been able to see because of, and although I think they're recorded, but just so everybody out there knows, that's the Healthy California for All Commission. Always trying to get the names right. Created by, is that right? I think that's right. But it was a commission created by the legislature and populated by people appointed by the governor, and also
they stole our name, you know, because we came up with Healthy California, right? And so, and then we came up with Healthy California for All,
right.
And then they decided, okay, we're going to have the Healthy California for All Commission, you know. So
yeah.
Yeah.
And I think one thing is that if you know, it at some level, if the governor says, you know, it's important for me to do single payer, that I have to have sugar corn pops with my breakfast for a couple of days in a row before I really get focused on it, then like I guess we should send him a couple boxes of sugar corn pops. Like if that process, and it does seem like I know what you're talking about for sure, in terms of the that it looks like minds maybe shifting within that process. And some of it is that they've actually at some of the meetings have been talking about actual kind of the policy basis for like the health science policy behind single payer that's out there. And it's when you look at it head on, it's very convincing. And so if you're actually open to hearing about it, and you're confronted with the data and confronted with the problems that we've had, and you start to say things like, well, can we really solve that by, you know, like just last week, for example, a major study that came out on medical indebtedness, that came out in the JAMA, and how much medical debt Americans have, and how terrible that is, and also that it's bad for you to have healthcare debt. It's not just bad for you financially, it's bad for your health, because now you start to judge any new potential health expenditure in light of the fact that you have a mountain of debt sitting in that you owe already. And you know, I've even been in offices too where they like have a little flag that says like, this person still owes us money and blah blah blah. I mean, just things that like it creates barriers that are terrible. So yeah, and so how are you going to do that? Just by like nipping, you know, like little changes here and there, when so much of our system right now depends on so much out-of-pocket expenditure, which is where debt comes from, is when somebody gets stuck with bills that they have to pay for. So it's so as people start to kind of like examine all those problems, and they're confronted with data for it, you're right, they may be changing their views. And so yeah, go ahead, I see your hand.
Well, just another thing on politics and the commission. You know, I mean, who are the hardest core, you know, resistors on the commission? I mean, at this point, it's got to be Senator Pan, right? I mean, it's got to be Pan and Wood, and it would appear that Assemblymember Wood has softened. I mean, you know, that last commission meeting, he was almost talking like he's on board for single payer at this point. I mean, Pan is still talking against it, but Wood is talking like he's, you know, in alignment. And if we know anything true about politicians, you know, they're the consummate weatherman. They've got their finger in the wind, and they're going to blow towards the people if they think that'll get more money or more votes, or they're going to blow towards money if they think that'll buy them more votes. You know, so they got their finger in the wind, and so I think that that, you know, that's kind of the pressure point at this point, is those commission hearings, even as painful as it is to sit through them and watch and have, you know, feel like we have no input at all. The sentiment, the mood, the feeling there is changing. I mean, you know, just to have a time more certain, like that they said they're gonna complete their proceedings and have a report for the governor by the end of the year. You know, to me that's awful, because how many more people are going to die before the end of the year? But they have not mentioned that previously. That just came out in the last one or two meetings, and that they're actually looking at the end. It's completely consistent with what you know, the AB1400 author Ashkara now considers to be his plan for moving the bill through committee. So once he has a report from the commission, you know, assuming it's favorable, which is a big assumption, I know, but assuming it's favorable, he can then move it through all those members of the assembly. The one kind of error, I think, you know, is to assume that it's any one person holding it up. I mean, last time SB 562, we all kind of looked at Anthony Rendon as the devil, and it's kind of easy to do that with Rendon, you know, frankly. But in my opinion, seems so unlikable, you know, maybe. But it wasn't, you know, just Rendon. I mean, you know, it might have been Jerry Brown for that matter, but it was. It's a whole host of them. It's whack-a-mole. You know, when one pops up, you know, you get one, and new one pops up, that kind of thing. So I think it's a matter of us all doing, you know, what we've been doing, trying to influence all the legislators across the state, you know, as much, as frequently as, you know, more and more that we can, and then that, you know, kind of raises the bar, raises awareness, and pushes the whole conversation to that pressure point, which is the commission at this point. So that's it.
No, thank you. No, and I appreciate kind of hearing, because I had not been able to see it myself recently. So it seems like some things are moving. So I see, let's see, a question, or it's a comment that, let's see, Jim Dillon from Facebook says, way too many Americans bankrupted by healthcare debt. And maybe he was responding to some of the press coverage of the story from JAMA on the magnitude of American healthcare debt and how widespread it is that people have healthcare debt. And then among the people, one thing that's kind of interesting is, like, there are people who have healthcare debt and there are people who don't. So if you take the average across everybody, well, that does include a bunch of people where that number is zero. But if you just take people who actually have a non-zero amount of healthcare debt, it's thousands of dollars of debt is the average. And it's let's see, Dylan Foster had said that. And so again, I think then, like, how would a bill like this make make people never again have healthcare debt. Although I will say that I don't, as far as I can tell, have not seen anything in this bill that does anything about anybody's existing healthcare debt. I don't think it has some sort of debt forgiveness or anything like provision in it. Maybe a good idea, but it isn't in this bill. But how does it make it so that people don't actually ever get healthcare debt again? Well, the answer is by eliminating out-of-pocket expenditures entirely, right? So how is it, where is it that people, what happens, where do people end up in healthcare debt? So one is they get bills, they have no health insurance and they just go somewhere and they get a really big bill that they can't pay. Another would be that they have to take, they're indebted related to their deductibles, basically, or even in theory, even co-payments, right? That those would be all kinds of things where, especially where the money has to go to a provider, the person gets the services, they don't pay that, and then now it's a debt. Maybe some providers, I think, will send them to do things like collections, essentially sell that debt to other people because they don't want to try to collect that themselves. Anyhow, that's sort of where that comes from. So if you have a healthcare system in AB 1400 would have that, where there's no deductibles and no co-payments, and pharmaceuticals are free, and other stuff is just not charged, then there's no healthcare debt. So that's how the bill solves that problem. So what else do you, or maybe we should circle back to a question that Erica had asked in the chat. And it was a question, maybe you want to ask it, since it sounds like you're kind of referring to it in general, if you're still there, about profits and nonprofits.
Yeah, and then there was so much, so I'd love to comment on some of the stuff that was said. And, let me just read this. This was on our stories today, put out on Instagram by Bronwyn Major. Thank you, Bronwyn. It's hard to read, but she wrote, this woman writes, my insulin fell out of the fridge and my kid put it back in the freezer by mistake and thereby destroyed, and insurance won't replace it. So that's $800, which luckily I have, because if I didn't, I'd simply die, which is what happened to one of my students. So time to get to work. I know we're all talking, but we're talking about life and death. This is so serious. I know you guys know this. I'm not preaching to you. I'm just preaching to whatever Facebook land. And like Dylan Foster said, it's life and death. It's quality of life. People are losing their homes. They're deciding, do I pay rent or do I pay health care? When this rent moratorium is lifted, people are pissed about, homelessness now. Wait till that gets lifted. And AB 1400 doesn't solve all of it, but it goes a long way. There's so much interaction that happens with this bill, because people will have more money in their pockets. They will have health care. They will have mental health care. So this is the most urgent thing, and everything that delays this bill from being passed, because you got to have a bill passed to do anything else, is unacceptable to me. I have a harsher view of the commission. I think the commission is completely bogus. That's my opinion. I think we have 3 advocates on there for single payer. To me, Dr. Bill, talk is cheap. So, like Beyonce would say, put a ring on it, wood and pan, stop your talk, let's see some walk. And back to the Newsom thing, like when you were saying, Dr. Bill, can we pinpoint this on one person? maybe Rendon, maybe not. And you said maybe Jerry Brown. You know what? There is one person. There is one person. Just like on the national level, what President Johnson did with Medicare, I know you have all seen the film, that was the person who rallied his Congress and said, make this happen. Oh, but we can't. It's really hard. And there's going to be a lot of fallout. Make it happen. Make it happen. He championed that. It would be a different game if Newsom said, make this bill happen. Get it on my desk. So he has the power to do it. It's that simple. And, you know, and really it comes down to money, which actually kind of is part of my question. What I wanted to ask originally was, when you talked about the for-profit institutions, like for-profit hospitals, Ron, and with CalCare, and then you said they get like turned into nonprofit. So I'm curious if you have, you know, any more information on that. And I was thinking of, so Prime Healthcare is a hospital chain. They have 8 hospitals in California, and I think it's like 42 across the United States. And they threw a big fundraiser for Newsom during his election. So there's my tie in there. But what happens there, Ron? So like, do they get, like, it's a family that owns this hospital. How does that work? Do you have that answer?
Well, the bill, I mean, the bill has some particular language about that. So first, go back to like how hospitals would be paid in CalCare. They would be paid with a global budget. And so that means that it's no longer like a fee for every, like a little payment for every little different thing that happens at the hospital, but it's budgeted more like, I mean, I often just say, just like the fire department, you know, one firehouse has a certain budget to do its thing, or one branch, you know, one branch of the library has its annual budget, basically. And while there can be like little adjustments made to that, overall, that it has this budget. And the budget, there's some more details about that in the bill, that there's like operating budgets and capital budgets, and that you can't use money for one thing from the other thing. That you can't sort of like, if you run an operating surplus, you can't take that money and buy some new machine. That isn't something you can do with that. So what it then talks about is that the words it uses, a margin, not a profit, is not profit, but it's a margin. And what it says is that if you have you've been given your global budget, and let's say like unexpectedly something costs less than it used to, or something like that, or there's just less, you know, the predicted demand for services at that hospital just turns out to be, it was more than predicted, or less happened than was predicted when the budget was made. So they end up with like some extra money. That money doesn't necessarily like have to get sent back to the state, but it has to be spent on patient care in some way. And then it also couldn't be spent on capital expenditures. So it's also been a little while since I've looked at the details there, but that is, you could say it this way, which is that for institutions, there's no line item for profit in the budget.
Wait,
and so then does that institution now have to change? Does it have to change from being a, like they can't make profit, whether they are allowed to, whether they have to change their IRS classification? I guess like that's maybe a hyper detailed question that I like, the bill doesn't say that, but the bill does have a very clear intent, and that is to end for-profit healthcare in California by institutions.
So can you break it down a little bit more for me? Like if you may not know.
No,
but
well, so that's Prime, the people who gave the money, they're like a chain, right? that a chain that owns some hospitals.
Right. So like if
Right.
I'm the person that owns it
Yeah.
and I'm making multi millions, possibly billions, now CalCare comes along and you're Ron, you're like, I don't know, the head of CalCare. I know I'm just making this up. What is it? Do you look at me and you're like, okay, here's your budget, owner of Prime Healthcare? Like, I just like, I'm still not.
Yeah, right. There has to be a budget negotiation between that owner and that. So the state doesn't take over their hospital. So that's not what it is. It's not like a nationalization of the hospitals or something like that, or a statization of the hospitals. So there's a negotiation, and what I would imagine is that the board will have they'll do things like start with what revenues were at that place in recent prior years, or what some other metrics of what demand was at that place, and then that place there's a negotiation still and a contract they have to sign. So let's say they're like, you know what, they might shut down. Maybe they would say, we don't want to do it. We don't want to contract to the state of California. And then, or they'd say, no, actually, we'll stay open, but we're not going to contract with the state of California. So then what happens? Well, there's some rules, like, for example, the private insurance companies, that goes away. You can't have private insurance that duplicates the services in CalCare. That's specified in the bill. So suddenly they've got nobody to pay them. And very few people can just pay a hospital bill out of their pocket. You can't run a hospital on like people paying cash for services. Like you can't run, that's not a business model that works. Stuff costs too much. And so so if essentially they'd be forced, if they wanted to continue to operate, to deal with the state. And so that's what would happen there. And yeah, I think it's possible that you could see somebody from out of state say, well, we don't want to, but maybe they'd sell the building to somebody who says, oh yeah, we can do it. But that it's an interesting problem, because who also would want to buy that building knowing that they're not going to necessarily get a return on their capital investment. So Bill.
Yeah, well, this also intersects with Erica's question about provider groups too, because, like, for example, Kaiser, and HMOs, Kaiser is not for profit. That's a non-profit provider group, as well as insurance companies. So I mean, so just calling it, not non-profit, we all know that you can get around that, as Ron says, using other terms like margins and at-risk payments and kind of weird kind of financial manipulations and stuff. So, but the point is that the intent of the hospital should not be to make a profit, and so global budgeting goes a long way to remove that intention and that part of the business model. So I would like to once again say that you don't have to eliminate provider groups, because again, there's a role for individual providers, group practices, very large institutional groups like teaching facilities. There are roles across the whole spectrum of healthcare providing, that exists in all those advanced countries around the world that have similar either single payer or otherwise universal healthcare systems. So there, no groups have to be dissolved, but their business models have to change if they especially have ownership of facilities that then need to go to not-for-profit status. And that includes very large groups like Kaiser.
Yeah, but I mean, I think that there could be some situations like this that would take time to work themselves out, right? Like if a for-profit hospital decided it didn't want to continue, it might be that things like, maybe the doctor group or like a group of doctors or somebody or a group of people associated with that hospital would create a foundation to run it instead. There may be there may need to be even like structures put in place to kind of like help with these types of transitions. And of course, there's nothing that per se prevents, I mean, the state could spend capital money and it could buy hospitals. Like I don't think there's anything that would prohibit that, doing that. But it doesn't, it's pretty clear though that the bill doesn't just make the state take over all the hospitals. Because, for example, we also have a lot of public hospitals that are run by counties in this state, some counties more than others. Los Angeles County is one where there's considerable kind of like public ownership of hospitals and counties. And those would still continue to exist. And I think that their status wouldn't change that much. It probably just would be better. They'd probably be paid better than they're currently paid, because they wouldn't just be trying to squeeze money out of like kind of just like the taxes in the county. They'd be now getting reimbursed with that sort of more generous pool that is where the private sector is getting paid for those, like the hospitals like Cedars-Sinai or whatever, right? So who are billing insurance. So I think there's some interesting questions that I think Erica's question brings up some interesting head scratchers about how some of that transition would work. Because you see the Medicare didn't, when it got put into place, it certainly didn't like change the profit status of any hospitals. That's not, in this sense, things go beyond what Medicare does.
Which seems important, Ron, right? Because this is without controlling cost, or like this is part of controlling cost.
Yes, so the global budget thing is an important part of controlling costs. That's right. That's right. And right, in other words, that's one of the reasons why it'll work. Or another way of saying it is that I think it's probably right to say that profit is like a deadweight sort of loss on the healthcare system, and that it may not work in the same ways that it does in other parts of the economy. It's and it's for reasons like that economists sort of, across different ideological views, sort of identify certain areas of the economy as maybe a better idea to be done by the government, right? Like they're like, there's not really like a system of for-profit bridges to cross, the Mississippi River. Like it just like, It's like, it's actually like, it doesn't, that would be a bad setup. And, you know, even places where like, you've seen places where they like experimented with like private sector toll roads and things like that. It doesn't usually work very well. So yeah, Dr. Bill, I see you have your hand up.
I was going to chime in on the idea of cost containment, and I think the biggest factors, you know, we'd all agree on cost containment are cutting administrative waste, and also fraud and abuse, you know, which is hidden in this morass, what Gina calls the spaghetti, you know, of our reimbursement system or adjudication process for billing, and you know, the incredible standardization and transparency that comes along with having a single payer system. So at that point, it's all transparent, you know, and so there are no more hidden kind of backroom deals, negotiation, surprise billings, you know, all that stuff that inflates, perpetually inflates healthcare costs. So so that's what we're talking about. If you know, if I could even share my screen, I'll throw that up one more time, because why not, right? You can't see that too many times.
Yeah, I have it set up. You can go ahead.
Yeah, thanks. So, you know, but it's not just the spaghetti, but it's the lack of spaghetti. You know, like if you look at Canadian versus healthcare versus US healthcare payment systems, you know, I mean, this is so standardized and so transparent every step of the way. Compared to this mess, which is, you know, said before, 3 or 4 layers of this junk. Every one of these boxes and lines that connects them actually exists. So, so that's the mess that we have here. And with AB1400, we go to a system like this, which exists in Canada and elsewhere around the world, that makes, you know, their healthcare basically result in this, which is, you know, life expectancy, and they live longer and spend less as a result. You know, this is us. We don't live as long, and we're spending way more. And if you happen to be a Black male, you know, you're really up the creek. So, so that's because we have this. We have this crazy mess. So, you know, I just think we can't stress that enough. If we went to the Canadian system tomorrow, we would start saving that kind of money and saving lives immediately as a result. So.
Yeah, a lot of, I'd say, administrative and when people calculate like administrative costs in healthcare, they do include like profit as part of that, right? Like that's part of that overhead. It's list, you know, people use some different words, but administrative costs, overhead, it's in, or the medical loss ratio is another way of thinking of that. And some of these are like, I think health, maybe a very sophisticated health economist would say that is slightly different than that and that. But if you just think about like money that gets taken away from the provision of care, that's definitely one. And we're not talking about like people being paid to do their job, right? Like a nurse doing her job, or a nurse doing his job, or a doctor doing their job, or whatever. Like that's not what we're talking about. We're talking about like corporations and those types of profits. And then so administrative costs, big one. Pharmaceutical costs, big one. And I think actually global budgets themselves are another one. I think those are the big. Those are why a system like this that still covers everybody and provides better benefits than the current system still ends up costing less and not more. and that point can't be made often enough, I think. So what any other questions out there, Paul, that you've seen, or anybody? Brother Steve, you're often out there quietly with us, but not asking a question. But if you're listening, you have a question.
I listed a question, actually.
Oh, okay. What do you got?
The question is, I've heard, people have said to me that if we nationalize the healthcare system, that innovation if you take away the profit motive, that innovation and invention would cease. For instance, they found one way of treating cancer by making clones of diseases like AIDS, and then making it so that they attack the cancer cells, but they don't attack the rest of the body. And it was very successful. But without this profit motive, would single payer, mess that up?
Right. Well, what? Yeah. No, I think it's a good question, and I'm glad you asked it, because I think, like, when we're sitting here saying, like, yeah, we're going to take the profit out of the system, it's sort of like, well, like, does profit make restaurants make better food than hospital cafeterias or something like that? And so are you somehow like, or then, government cafeterias in government office buildings? And that's the kind of stuff that people worry about, right? But I think that when you talk about healthcare innovation, there's a whole lot of different things that you're talking about. The one is, I do not myself believe that the health insurance companies are a big source of innovation in healthcare at all. Like, they innovate in profit making. Like, that's what they do. They come up with schemes to, like, and that's, I'm sure if I had a health insurance executive on here, they would, like, who is honest, they would totally agree with that, right? Like they would say, like, yeah, like, we're not trying to, like, come up with better healthcare for anybody. We're a company, and we're trying to make, actually, it's my duty to my shareholders to, like, try to make them more money in some different ways. And they might say, yeah, like, if we try to do certain things and make more people want to be our thing, that, but that's not, let's just say in practice, that's not what we're talking about. So then I think one thing you're talking about is in the research and development of new, for example, therapeutics, like you were saying. And let's just say that in the United States, that has been a mixed public and private sector activity, where in fact the big risks have been primarily taken by the public sector in things like the National Institutes of Health. And it is the case that some of the drug development, important aspects of drug development happen in the private sector. I think it's wrong to say that doesn't happen, but it's not like, one thing this bill, it doesn't end pharmaceutical companies. This doesn't do that. That's not one of the things it does. It does anticipate that that the state will be negotiating with pharmaceutical companies, and that could have impacts on their profits. I imagine it would. But when people study kind of like R&D at the pharmaceutical companies, it's also not often like they spend a lot on marketing, for example, and a lot of R&D at pharmaceutical companies is like Me Too pharmaceuticals. It's just like duplicating the same, kind of making slightly different versions of things that are already out there that don't change a lot. So I think that's an important thing to say, which is this bill is not like nationalizing pharmaceutical companies. And so to the extent that some innovations, and I would quibble about what comes from the pharmaceutical industry, that doesn't all just disappear because of the passage of this bill. And then you have to, like, kind of say, like, well, do institutions themselves, like, is there is there like clever management or something at some institutions versus other institutions that are making patients' experiences better or that kind of thing? And I mean, I think it's right to say that that is not dominated in particular by for-profit institutions. And they're like, for some reason, I find it easy to compare this to like universities. I think are a good comparator, which is that there are public universities and private universities and the for-profit ones and the not-for-profit private universities. And easily, like of those three, like the worst ones are the for-profit, you know, and so there's plenty of like innovation, and I guess you'd even say like kind of competition between public universities and nonprofit private universities to bring students in, and they develop programs, and people like go into management at those places and care about what happens there, and not just, you know, they aren't all, there are people who are like professional managers, and I just think that there's plenty of examples of that innovation is not only driven by profit, it's driven by people who dedicate their lives to stuff and care and try to come up with new ideas to do things. And, you know, I mean, nobody says like, what's the right amount to pay a good CEO of a hospital? And I'm not now talking about like you know, just sort of like crazy, but just like, you know, it's a good question. Like there still will, like, you know, hospitals are still going to need to find people to run hospitals who are smart people, and you're going to have to pay them to pay them to not go do other work. So yes, we're close to the end, by the way. Erica.
Just on that point, I remember listening to an interview with Dr. Jonas Salk's son. And you know what motivated him to find the polio vaccine? He worked like on the floor beneath where people and children were put into what you guys know, the iron lung, which was such a devastating thing. And that's what motivated him for the to create the polio vaccine, not money. And as we all know, he didn't patent it. And in the famous interview where he was asked on the news, aren't you going to patent this? And he said, can you patent the sun? It belongs to everyone. So that's, you know, a perfect example of your point, Ron, that, you know, most people are in the helping profession, the health profession, doctors, nurses, research and development, because they want to cure people. They want to ameliorate their suffering and their pain. So thank you.
Yeah, and my entire, like, or, you know, the places where I went to medical school and things like that were just like chock full of people like that, right? Like the, you know, and that and people where, you know, for them, the like glory is actually one of their big payoffs too. Like they want to be the person who helped solve who solved polio. I mean, like they're and that's obviously related to doing good things in the world and being thought of well by humanity for doing good things in the world. Now, we should come back to this at some point too, because somebody could say like, okay, well, he invented it, but what about the manufacturing process for that vaccine? Who did that? You know, so maybe there's still questions out there. But this AB1400, this bill doesn't end pharmaceutical companies. So nobody should pretend that it does. That's not right. It does. People would negotiate. This state would negotiate. It would change the relationship with pharmaceutical companies. We're past our time. Thank you for everybody who put up with like kind of madness related to the Zoom and the thing. It's a good discussion. Yes, and so clearly, like we need to maintain focus on AB 1400 and the passage of this bill. Thank you to the California Nurses Association for making this bill happen. Thank you to Healthcare for All Los Angeles, PNHP for sponsoring this activity so we can keep it going. And we'll just keep going. Week 19 is in the books, and we'll see you week 20 next Sunday.